House Appropriations Subcommittee on Medicaid and Behavioral Health will come to order. Clerk, will you please take the roll for today's attendance?
Chair Van Workum.
Here.
Vice Chair Green.
Present.
Representative Roth.
Here.
Representative Kuhn. Representative Robinson.
Present.
Vice Chair Rogers.
Here.
Representative Glanville. Mr. Chair, you have quorum.
Thank you, Mr. Clerk. Representative Rogers moves to approve the minutes of April 15th meeting. Seeing no objections, the minutes are approved. All right, committee members, today we're talking opioids. We've got the Opioid Task Force and the Opioid Commission here today to talk about the settlement dollars that the state has received. There's a lot of questions about it. It's a unique circumstance of how these dollars are administered or sent out based off of the settlement language, with a lot going directly to local governments and then a portion going to the state government. We haven't seen much use of these dollars. If you look at the fiscal analysis, there's a lot of unspent dollars here. So we're going to take some time, understand what's going on there, and see where the state has some gaps and where the needs are related to the opioid crisis. So with that, the first presentation will be by the Michigan Opioids Task Force. We have Thomas Stallwell from the department, as well as Dr. Natasha Bagdasarian, the Chief Medical Executive at the Department of Health and Human Services. You are welcome to come up to the table here and provide the presentation. Thank you.
Good morning. Thank you so much for having us here today. Thank you so much for being interested in this work and for all that you do to combat the opioid epidemic. I'd like to just start out by introducing myself. My name is Dr. Natasha Bagdasarian. I'm the Chief Medical Executive for the state, and I'm here with Thomas Stallworth, who is a Senior Advisor at MDHHS. What I'd like to do is to give you an overview of where we are in the opioid crisis with overdose deaths specifically. Now, this is a problem that we've really seen emerge since the early 2000s. And we've seen this number of overdose deaths just go up across the country as well as in the state of Michigan. And there have been a few key events that have really made this trend what it is. The first thing we saw in the early 2000s is the rise in opioid prescriptions. We had a lot of unethical behaviors happening, a lot of misinformation about how addictive these medications were. And so they were really started by this overuse in opioid prescriptions. In around 2010, we started seeing heroin come into the picture. And as people were coping with the addictiveness of these medications, they were going through symptoms of withdrawal. And heroin really became one way that folks could manage some of the really terrible symptoms of withdrawal. So we saw this rise in heroin use, and then we started seeing contamination of a lot of street drugs with things like fentanyl. And we're now seeing contamination of pills and powders that are sold outside of a pharmacy with all kinds of substances. We're seeing things like fentanyl, which make them extremely deadly. We're seeing contamination with things like xylazine and medetomidine. Again, all substances that are making the drug supply more deadly. We then started seeing an increase in opioid and stimulant use. So a lot of polysubstance use, as we call it. And what you saw was those numbers really had started to decline a little bit before the pandemic. A lot of the social situations around the pandemic, the isolation, loneliness, again, led to those numbers going up. Now, in the last couple of years, the good news is we've started seeing a decline in overdose deaths, both nationally and notably in Michigan. We are seeing a real decline in overdose deaths in Michigan. However, we are still on track, based on our estimates of last year, to see about 2,000 overdose deaths in Michigan in 2024. And if we think of those numbers, those are all people's loved ones, family members, and so those are 2,000 deaths that were entirely preventable. Now, I did want to talk about where we're seeing the impact of opioids, and the answer is really everywhere. We're seeing the impact of opioids and of substance use and of overdose deaths, both in urban parts of the states as well as rural parts of the states. You can see we've got some areas in the Upper Peninsula that are grayed out, and that's because the sample sizes are too small, but those communities are still impacted. So every single part of the state is impacted by overdose deaths. Now, going back to the Michigan opioid settlement, these are settlements, I talked about that prescribing behavior in the early 2000s. So these are settlements from opioid manufacturers, distributors, pharmacies, totaling nearly $1.6 billion by 2040. The way the settlement was structured was that 50% would go to local governments and 50% would go to the state government. There was no oversight between those two parties. The state would not oversee local or vice versa. And if I can just talk about a little bit about how the funds are coming, a lot of these settlement funds were paid out up front, with then decreasing amounts over those latter years. And what that means is that the money was sort of paid more so initially up front, but we have to make it last because we know this is not a problem that's going anywhere. And in fact, as I look ahead, some of these issues are worsening. So when we see contamination with things like medetomidine and xylazine and fentanyl, those things are just worsening. So how do we prepare and deal with what's happening now as well as what is to come in the future? The other little nuance that I want to add here is there are some entities that we have agreements with that could go bankrupt. And so if bankruptcy happens, if some of these entities go out of business, that means it puts that later money in jeopardy. Telling you a little bit about the Opioid Task Force. So this was based on an executive order initially in 2019, then updated in 2022. The current iteration of the Michigan Opioid Task Force is from that executive order in 2022. I am the chair of the Opioid Task Force. We were charged with developing and recommending response actions to the opioid epidemic. Our charge is to look for root causes, to guide strategic planning and policy development, and to advise on opioid settlement spending. The task force is advisory and reports to DHHS and to the governor. And the current membership was appointed in June 2023. And what's nice about the makeup of our opioid task force is we have folks who are working on the front lines of this issue from every single part of the state. So we have representation from all over the state. We have folks who have lived experience. We have folks who work on the front lines of treatment, of recovery, who really understand some of these nuanced implications. And so it's people coming together with very different backgrounds and making pretty strong recommendations. The way that we've structured the task force is we have 4 pillars. Because we believe, again, you've got to prevent what's happening now, but we also want to look ahead to the future and make sure that we're preventing what could happen in the future. So the 4 pillars are prevention, harm reduction, treatment, and recovery. Prevention is really focused on how do we prevent addiction from happening? How do we prevent this from becoming a problem? And when we worked with the task force as a whole, we said if there was one single thing you could do, one single thing with prevention, for example, what would that be? How would you really make the most traction? And the task force said if we could delay as long as possible the first use of drugs and alcohol in whatever age group, if we could delay it and push it out as long as possible, that reduces their risk of substance use disorder later in life. So if we have folks who are not drinking until they're age 21, who are not trying other substances before they're age 21, that reduces their risk of substance use disorder later in life, and we felt that was very protective. For harm reduction, so we know that folks who are currently battling addiction, they're at really high risk of overdose. And we see the 2,000 overdose deaths that we predicted in 2024. In the years before that, it was about 3,000 overdose deaths every year. So we know that there are agents out there that can reduce overdose, that can actually reverse overdose. The biggest issue with overdose is that people stop breathing. So those opioid receptors, they get bound by fentanyl or whatever is in their medication, and folks develop respiratory depression and stop breathing. There are medications like naloxone that will bind to those same receptors, displace the opioid, and allow people to start breathing again. And those are the best bet to reverse opioid overdoses in people who are currently using drugs. Treatment. We want to make sure that we are making treatment as widely available as possible, that folks have access to treatment that they're not afraid to use. So we know a lot of people didn't choose treatment because the symptoms of withdrawal are so terrible. I'm sure you've heard the term dope sickness. When you're withdrawing from drugs, you feel absolutely terrible from head to toe. And so what can we do to offer people treatment in a way that is humane and acceptable? And there are now medication-assisted treatment. There are other ways that we can make treatment more acceptable for folks. And then we've got recovery. And for recovery, we really want to make sure we're supporting people in their journey so that they don't backslide. And part of that we've identified with the opioid task force is making sure that they've got housing, for example. There are a lot of people who are leaving treatment who don't have housing, and it's really easy to backslide if you're in a situation that is just not tenable, where you can't address your basic needs. So making sure that folks have some of those resources are really important. So these are the most important priorities identified by the task force in those 4 pillars. And with that, I will hand it over to Tommy Stallworth.
Thank you, Doc. And to the chair. Can I move this a little closer?
I don't think it will.
Oh, okay.
The slides for you.
Okay. So I'd like to spend a little bit of time just I think doing some level setting around how substance use disorders are being funded overall. And I think it's important just for context to understand where the opioid settlement dollars fit in. As you can see, Michigan, on average, spends approximately $300 million annually on publicly funded SUD services. The opioid settlement dollars represent about 25% of that on average. As you can see, we've tried to outline for you the various sources of that funding. In addition to the general fund that you all help appropriate in support of SUD services, we also receive funding from SAMHSA, from the CDC, and a large contributor is obviously Medicaid. Dr. B actually walked through the 4 pillars, and we tried to identify an estimated total of what each of those buckets have looked like historically for you. But in addition to that, we've added a column called maximizing impact. And so it's important for us to note that the funding and investment we make there is largely designed to help improve our reporting processes, so that we have a completely transparent process for the public. You'll find on various websites that we've developed all of our problem analysis, our data collection, our reporting that's available to help you and the public understand what progress is being made. But it's also important to note that that investment has been critical because, probably no surprise to you, collection of data around opioids initially a year ago was very, very difficult to do. We actually were looking at data that was 2, 3, 4 years old. We've made a tremendous amount of progress since that time. We've also using that investment to help build collaboration with local units of government, municipalities, and counties who are receiving opioid settlement dollars. And that collaboration is designed to see where we can establish mutual agreement on goals and objectives, and then leverage the funding that we have for maximum impact. Looking backward at what we've accomplished so far, our goal obviously is to be a leader in our response to SUD needs and in responding to the opioid crisis. And as you can see, we've actually dropped, the state of Michigan has actually dropped from 14th highest in fatal overdose rate to 29th, which is a significant accomplishment over the last 6 years. And so we are making progress. That progress is driven largely by our efforts in the media space to drive up awareness, designed to help prevent the use of illicit drugs, and as Dr. B explained, actually to encourage folks to delay first contact with illicit drugs. In the harm reduction space, you'll see that we've actually crossed the 1 million mark in terms of distribution of naloxone kits. That has a direct correlation to reversing overdose deaths and reducing our overdose death rate. And then lastly, we've increased our clients served from 10,000 in 2019 to now over 100,000 in 2024. In the treatment space, we've incentivized 64 providers who didn't previously provide SUD care to do so. And as such, they've served over 12,000 citizens. We've done that by incentivizing their participation through a loan repayment program, and we'll talk a little bit more about that as we talk about the need for future investments. And lastly, we've invested in adding more than 200 additional beds in our recovery spaces, as Dr. B discussed. As folks go through that recovery process, they need both transitional and temporary housing, and then the ability to migrate into permanent housing situations. Often that includes the ability to house their families. Next slide. Where do we need to go now? We've made some significant progress in my mind, but we've still got improvement to make. And so we've tried to outline and identify through our analysis where strategic opportunities exist to move the bar and to use opioid dollars, opioid settlement dollars to do that. Again, as you can see, compared to other states, Michigan still exceeds the national average by people 12 to 17 years old in their estimated illicit drug use in the last month. 7.6% in Michigan as compared to a national average of 7.3%. 30.5% of people between 18 and 25 years old in Michigan used illicit drugs in the past month, compared to a national average of 26.7%. So you can see we've still got a high rate of use, higher than the national average, that we need to address. In terms of addressing it, we've looked at, and as we've talked to providers of services, universally, what we've been told is that we don't have the workforce to provide the service. And so while we continue and want to invest in facilities and outlets for services, we still need to build that workforce. And you can see our analysis indicates that Michigan is behind the U.S. average. It's behind the best in the Midwest. And it's behind, obviously, the best in the United States, which is Massachusetts. If we want to close that workforce development gap, we need approximately 13,000 new SUD counselors and approximately 2,000 more psychiatrists who will provide these services. Next slide. And then lastly, in terms of strategic investments, and again, I just want to say these are, the task force has identified these areas as places where opioid funds can be strategically deployed to drive improvement. Dr. B talked about the homelessness situation and the nexus between homelessness and substance use disorders. And as you can see, in 2024, over 1,000 Michigan residents were discharged from publicly funded SUD treatment services and lacked stable housing. In other words, were subjected to homelessness. In order to manage that recovery process and help people stay compliant with their needs and desires to be sober and continue their recovery process, we have to invest in making sure there is access to permanent and affordable housing. Next slide. And then lastly, I just want to walk through really briefly what our proposed spend plan is for settlement dollars and how we believe those will move the needle. In the prevention space, you'll see we're asking for approximately an appropriation of $10 million. again, to help target young people, parents, raise public awareness, and to support school-based programming that helps prevent first use and avoids later substance use disorders in life. In the harm reduction space, we want to make sure that we are improving services in underserved areas, and we have a number of areas in the state where there is no service. We want to make sure that folks have access to these services, and of course, we want to double down on the naloxone distribution across the state and toward driving down our overdose death rates. In the treatment space, we talked about workforce development, and in that space, approximately $15 million is the request. And that largely will be used for the development and expansion of loan repayment programs, scholarships, internships, all designed to incentivize, attract, recruit new entrants into the workforce to provide these services such that we can close that gap and improve access. And then probably our largest investment request is in the space of recovery housing, approximately $25 million. That's increasing beds for temporary housing, those in recovery, and then helping to drive the development of new permanent affordable housing for folks who are in need. I talked a little bit about the collaboration effort. We've got a number of counties who have agreed to work with us on these prospective initiatives and want to combine dollars, again, for maximum impact in their local areas. And we've also engaged philanthropy around these initiatives and these priorities as well. And folks like the Health Endowment Fund, Community Foundation of Southeast Michigan, have also identified areas in these priorities they would like to work with us to drive up investment, maximize impact. And then lastly, I just want to bring to your attention, I talked a little bit about the investment in data collection, problem analysis, and reporting, and you'll see the multiple sources of data that are now available for you and the public, which I believe are tremendously rigorous, far better than what we've had in the past in terms of helping outline progress, understanding both geographically and across other demographics where we're experiencing hot spots and our approach to attacking them. So with that, I'd like to open the floor for questions if you have any, Mr. Chair.
Thank you. Thank you for presentation. I know we've got several questions from members about what the task force has been working on. Representative Green.
Thank you, Mr. Chair. I have a couple questions entailed in the first question. Okay. Thank you both for being here. Now, inside of our opioid task force that you guys are presenting on, is this the task force that the governor set up for the department separate than the legislative opioid task force? Okay, great. How many people on the DHHS task force? That's number one question. How many people are there on the task force? And then number two is, how many of them are actively treating patients at this time?
I don't have that answer.
I'm sorry, I don't have those numbers off the top of my head, but we can certainly circle back with you on that.
Are there anybody from the department's task force that are active in treating patients?
There are several people on the task force who are working at SUD centers. So there are people who are running harm reduction programs, who are running treatment programs, recovery programs. But in terms of their, do you only want to know about treatment or the whole spectrum?
I would like to be blunt, I would like to know if the people on the task force are sitting in a cubicle or if they're actually working with people on a normal basis.
Yeah, they're actually working with people on a normal basis. I'll give you a couple of examples. One of our representatives from the west side of the state, from Grand Rapids, he runs a facility where they are handing out naloxone, and they are the very front line in preventing overdoses. We actually have a few people who are working on the front lines of those harm reduction programs. We have a few people who are running recovery centers, not just minding the books, but who are in there and in the sites.
Mr. Chair, I have a second question if you want to go to other, go with that, okay. Looking for my numbers here. We had talked about getting more individuals into the workforce. So would changing the mental health code to allow private entities to charge Medicaid for services be a solution to getting more people into the workforce? So that those entities providing services can actually charge for them instead of having to go through the hoops of the PIHPs and the CMHs in order to actually get payments? Would that be a good solution?
Representative, I'd have to take a deeper look at that. Obviously, administrative hurdles, we'd like to avoid where possible. That's not some issue that reshaping or restructuring like that isn't something I don't think has come up in our task force meetings.
I'll tell you the biggest barrier that people have raised, and that is reimbursement rates. So they have raised the fact that mental health providers already get reimbursed lower than other types of clinical providers. And then when you're talking about substance use, it's even lower. So the obstacle doesn't seem to be who can accept Medicaid, but rather people are not willing to go into substance use treatment. They're not willing to go into that field because one of the obstacles is reimbursement is so low. And so even folks who are social workers or psychiatrists or psychologists, they go into other areas rather than substance use disorder because reimbursement's much higher if, for example, you're doing private one-on-one counseling for non-substance use issues.
Representative Roth.
Guess I'm on. Oh, there it goes. Thank you, Mr. Chair. Thank you guys for presenting today. Are all counties participating in the opioid settlement dollars?
So all of the PIHPs are participating, which have county representation, but we don't have one single representative from each county. But all the counties are represented within their PIHPs.
Okay. I know when it first came out, some counties were hesitant of getting involved or whatever in the dollars, and just making sure that. The other thing, do you think that groups that are preventative in their nature are participating? Are we missing some of them? I know at one time in a couple of my counties that I represent, there were probably some prevention people that are doing great work that weren't necessarily being observed by their county as getting some of the funds. Do you think we're better at that? Do you think we could still improve on that?
I think, Rep, it's a fantastic question, and I'd say I responded to that in two ways. One is it's been very difficult to fund prevention work adequately, as you're well aware. And yes, it's as such, we have a number of great programs that don't really have the funding that they need. So can we improve? Absolutely. And the work we're doing now and the investment we're asking for is designed to help drive that improvement.
Is there anything the legislature would be involved to help you do that, or can you do it inside of your task force now?
I think we have the capacity to do it inside of our task force. Obviously, we need your support, we've got good representation on the task force from a prevention standpoint, and the work we're doing with the counties is really important. You just talked about folks in the counties who felt like they were, underfunded, under-resourced. But those representatives actually will help us define and identify some of our better providers so that we're making wise investments and working with good, solid partnerships on the prevention side.
Thank you.
May I add something? There are a few key messages that we're trying to get out to the public. One of the messages I mentioned is, delaying first use of trying any drug or alcohol, making sure that parents feel comfortable talking to their kids about this topic, and also arming people with the best information possible. So one of the things I think a lot of Michiganders don't know is that if you are buying a pill or powder, you have no idea what's in it. So making sure that those messages get out to communities, get out to some of those trusted messengers, youth groups, whoever is able to talk to kids, whether it's social media. We're working on the how, and the funding that we're requesting in the appropriations, I think, could be really key for getting that message out, that if you're buying a powder and you're being told it is one thing, it very likely isn't. It's very likely a whole mix of things that could lead to an overdose.
Representative Robinson?
Thank you, Chair, and thank you for being here. Are opioids still being prescribed by doctors for certain things? So, okay, that's, as we know, that's an extremely addictive drug. So how much has the prescription rates curbed since the pandemic as far as opioids started? And are there any alternatives being created that don't carry that extreme addiction that opioids do? If you could share that.
Yeah, that's a great question. So, when I was going through my training back in the early 2000s, I started my training in 2005. And at that time, as physicians, we did not know how addictive these medications were. We were just sort of starting to hear about how addictive they were. And a lot of things have come into the landscape since then. One of the things is our MAPS system. That's where a clinician, anyone who is prescribing these drugs, needs to go in and take a look at their patient's chart to see what are they getting from other providers, what other medications are they on. The practice of prescribing the lowest possible dose for the shortest possible time is now standard practice. There is much more of that in medical school and other clinical curriculum, and there's much more awareness. Now, there are still a few bad actors, if I will, who are out there. But the problem, although it was started in the prescription drug space, has now spread outside of the prescription drug space. So we've got to really handle both of those things. But things like MAPS have really been huge in terms of making sure we're prescribing the right way. If you go in for surgery today versus 20 years ago, the way pain meds are prescribed, it's completely different. You're only given a very short supply. And then we've been talking to drug manufacturers who make medications that are things like nerve blocks, almost like, the Novocaine you get when you go to the dentist, almost like that, but on a bigger scale. And how can we leverage those types of medications so that more patients are aware that those are options instead of a potentially addictive opioid?
Representative Rogers?
Thank you, Chair. Thank you for the presentation. A couple questions, if I may. One, so can you talk about, so it looked like on the slides you had the projected spending. Can you touch on how much was spent this year and this fiscal year?
I don't know if it's in the slide deck. I know we had appropriated for this fiscal year approximately $48 million. In terms of where we are now on our expenditures, I don't have that number in front of me, but I can get it to you.
Thank you. And then could you also touch on how state spending has affected various populations? We've seen different trends over time, and so I'm just wondering, based on the need, how you decide as a task force the expenditures, and if there's any kind of state needs assessing, or how you kind of match up the need with the dollars.
Yeah, I think what you'll find as you go, even on some of those websites, we've cut the data and done the analysis where we can identify geographically underserved. We can identify unserved. And so even this year, investments in a women's clinic in Sault Ste. Marie, methadone clinic in Marquette, these were areas where there were absolutely no providers. And so our investment there helps close the gap. And so I think, again, you'll find some pretty rigorous studies, analysis of where there are hot spots, where we're losing, where overdoses are increasing. You'll also see where we feel like there's underserved populations. And that helps drive how we target those dollars. Sure.
There's actually a map on the dashboard. It looks similar to this, but this is the overdose death map. So it actually looks at overdose deaths and where we're seeing more of an overdose issue, and it maps it with where there are fewer resources. And so that allows us to really look at where there's a mismatch, and that allows us to see where the greatest need is and where the greatest gap that we could potentially fill is.
Thank you.
For your information, we've also cut the data by legislative district, both House and Senate. So you can actually see the counties in your respective districts, what overdose rates, death rates are, et cetera. That's all available to you.
Let me, I guess, follow up on that. I went through your presentation here, and it's kind of our job as public officials and the department is understanding what a goal is. And a lot of times our goals aren't the same, or we don't measure them the same way. And going through your presentation and seeing that map and the answer you gave in reference to her question was that map. What is the actual goal here? Is the goal to prevent fatal overdoses, and that's how we measure how well we are doing related to the opioid crisis? Is that the default goal? Or is there some other goals that should be more of the focus as we start to use or put these dollars into implementation?
I'll offer my perspective, which is probably more of a general citizen's perspective who's doing a lot of work in this. And just for some level setting, I spent a number of years running substance abuse prevention programming in the city of Detroit. But I think the task force has accepted a goal of wanting to be a leader in comparison to all other states in our ability to address substance use disorders overall and in our response to the opioid crisis, which I think an earlier slide we actually showed objectives in each one of those pillars that are reflective of the goals we're trying to set for ourselves and measure progress against.
Yeah, I mean, that all sounds nice, but as legislators and appropriators here, we want to see measurable goals. And I think that gets lost track of. We say all these great things that we're doing in these programs and new things that are coming online. I mean, you got a whole spreadsheet here of different things that are going on. But how do we find that actual measurable goal that we are being successful?
Mr. Chair, that's an excellent question. When the task force was coming together, we said, what is our goal? What is the ultimate goal? And what we decided was, essentially, our roof is on fire right now, and that is the overdose deaths. The overdose deaths are the crisis right now, and so our first objective was to reduce overdose deaths. That was our immediate objective. And then recognizing that there are all kinds of other harms, and that having substance use disorder is a harm. So next, those other goals come into play, but the first primary focus was to reduce overdose deaths. And then these are the sub-goals that would allow us to get there.
And at what point do you then review that goal, or is that always going to be? Because if that's the goal, you're going to have a certain strategy, right? I see the number 1 million naloxone kits. That may sound great, or that could sound horrible, right? If you think that's that's the answer, and just being on that front line and not worrying about the prevention. And I see the prevention and things like that, but it's kind of a cryptic goal, whereas the recovery one would seem maybe a brighter goal.
Yeah.
Of we've gotten this many people through the program and they have a job and are successful, rather than, hey, we stopped this many deaths. It seems if that's the goal, you're going to come up with a program for that goal. If the goal is the recovery or the prevention, it's going to be different goals. This one seems pretty end of the line goal
Absolutely, Mr. Chair.
than what we may need.
Yeah, I think it's both and. I think you have such an excellent point, and I agree with you wholeheartedly. It can't just be about the overdose deaths, but we felt that was the emergent crisis. So when the group came together, we were seeing 3,000 deaths a year. That's now down to 2,000 deaths. So the plan had been to reevaluate our objectives after 5 years and then start to focus on some of those other objectives in a really much more concrete way. But right now, we know that we can't just prevent overdose deaths. We must do prevention. We must make sure people are getting treatment, and we must make sure that people are in recovery as well. So I hope it makes sense, but it's both and.
I guess as you kind of point out at the start of just trends, and all of a sudden opioid became a higher trend of what people were doing. It could have been alcohol, it could have been stimulants before, what have you. I guess with a goal like that and the money that is being spent, how are you sure that what we are doing is actually the thing that's leading to lower deaths rather than maybe trends that are occurring? You talked about alcohol and drug use for youth before, but we all kind of know it's vaping now, right? So it's not necessarily that these programs that were put in place are preventing this from happening. It's something else that they're doing, or a different trend in the culture. So how are these measurable that what we are doing is actually the attributing factor, the causality of or correlation to the goal?
I can start, Tommy, and then hand it over to you. We have been real sticklers about making sure that all of these programs have metrics and have clear outcomes and objectives. And just to give you an example, so when we talk about overdose, the most sort of direct linkage between preventing overdose is medications like naloxone, which directly reverses overdose. And what we saw was that as we ramped up our naloxone distribution, we also ramped up the amount of naloxone being used. So a lot of that naloxone is actually used. And that, I think, has directly helped reduce that overdose rate. But all of these other things that we're looking at, we're making sure that we've got metrics and everything is very measurable. So in terms of our prevention, one of the big things we're doing is an opioid campaign right now. So hopefully you've seen on TV, on the radio, on social media, some of our awareness campaigns about how contaminated, for example, the drug supply is. And all of these are contingent on then looking at the messaging, how is it resonating, how is it impacting behavior, and then further tailoring some of that messaging.
Yeah, I would just quickly add, I love the question because you're really asking for, how do we know what we're doing is working? And so we've invested in building a staff and a team who's actually focused on root cause analysis. What's causing the problem? What are we doing, and how is it impacting the outcomes that we want? And so even on the example of naloxone, as you can see, it's not just the distribution of 1 million kits. It's the fact that we know where they're being distributed. We know where they're being used, and we can track where overdose reversals are occurring. So the 29,000 reversals are a direct result of having those kits out into the public space. And so we can begin to draw some correlations. Now, that's not to say that's the only variable. Clearly, there are more overdoses and overdose deaths to go down. The other place we're working, Dr. B mentioned the campaign, our public health campaign, but we've also discovered that through the research we've done that a significant number of Michiganders aren't getting the information they need to understand the risk of addiction when they're being prescribed an opioid. And so we can begin to message that to raise awareness. They also have reported that they don't have a plan for how to come off of the use of the prescription. And so these are areas that we think we can address and measure progress through surveys, polling, et cetera.
Well, thank you. Thank you for your testimony. I know several members have additional questions, but we have another presentation we need to get to, and thankfully I know that she speaks really fast, so that will hopefully she'll fit within the time frame allocated. But I think committee members, if you have additional questions, my team will assemble a letter and officially send it to you that can be answered as we go through this appropriations process. So thank you for your testimony. With that, next on the docket is a presentation by the Opioid Advisory Commission. Today will be presented by Dr. Kara Poland, the chair of the Opioid Advisory Commission. Doctor, thank you for joining us today.
Oh, there we go. Sorry. Thank you so much. I did provide the written testimony in your packets. In the interest of time, despite talking quite quickly, I am going to skip ahead a little bit. I just want to highlight that that I'm here representing the Opioid Advisory Commission, which I'm going to refer to by shorthand as the OAC. I am a board-certified and fellowship-trained addiction medicine expert with a focus on workforce development. Across the nation, my program has trained 30% of all the addiction medicine board-certified physicians in the United States. I just want to note that the data presented today was psychiatrists, which is not the workforce that is treating that is boarded in addiction medicine or addiction psychiatry. So we should probably look into ensuring that the workforce that we're training is the appropriate workforce. The OAC is a nonpartisan group of experts appointed by a combination of the legislative and executive branches. The commission first convened just over 2.5 years ago as a nonpartisan body housed in the Legislative Council with responsibility for advising the legislature on the appropriation of the state's share of the opioid settlement. We're now in the third year of receiving opioid settlement funds. These funds are anticipated to total nearly $800 million over 18 years in the state's share of the total $1.65 billion that Attorney General Nessel and her team litigated for Michigan. This represents an extraordinary opportunity, but more importantly, they also represent a responsibility. These dollars are different. These dollars are not part of the general fund. These dollars are not federal appropriations. These dollars are not state tax revenues. They were awarded to Michigan to remediate the harms of the opioid epidemic and address the broader addiction and mental health crisis, which has claimed the lives of thousands of Michiganders each year in recent memory. So today I'm here to talk about how we transition from opportunity to action and how we do so with accountability, transparency, and effectiveness. Let's begin by discussing our roles. The Opioid Advisory Commission, as you may know, was established by Public Act 84 of 2022 and is responsible for recommending to the governor, the legislature, and the attorney general the best ways to allocate opioid settlement funds. While we do not handle funds directly, we evaluate their usage and offer guidance through our recommendations to both the legislative and executive branches to maximize their impact. Our most recent report outlined 3 core appropriation recommendations that I want to highlight today. The first and most urgent is a statewide needs assessment. I think many of you in your questions were kind of getting to the why, the how. This is a statutory requirement. It is not a suggestion. The law requires the OAC to report annually an assessment of statewide and regional needs before making its recommendations. However, that needs assessment has not yet been funded or implemented. We cannot close service gaps if we don't know what they are. We cannot measure impact if we don't have baselines. We need this information to utilize these dollars safely and effectively. Our recommendation is to appropriate funding to conduct a comprehensive data-informed needs assessment that includes individualized county reports and to offer individualized reports to Michigan's 3 fires, including federally recognized tribal nations and indigenous urban organizations. To reduce duplication and costs, we recommend that we draw from existing data and assessments where available, including the shared data from MDHHS. We would like to focus on community engagement, particularly involving individuals with lived and living experience. This assessment is a foundational step toward equitable, evidence-based investment in alignment with the settlement terms and the OAC's statutory requirement to perform a detailed annual needs assessment. Secondly, current annual programmatic appropriations must tie performance metrics to every dollar. The relationship between the OAC and MDHHS is currently nascent but promising. Over the last 3 weeks, we've established new conduits of early communication. The OAC also thinks that it's promising that MDHHS has committed to building systems that connect spending to outcomes. That's encouraging, and we are aligned in that goal. But right now, there is limited publicly accessible information on where settlement dollars have gone over the past 3 years that includes outcome-based measurement of what those investments have produced and what success looks like in measurable terms. We propose a joint commitment to transparency, including performance dashboards, regular updates, and clear metrics tied to program funding. The OAC feels strongly that we cannot improve what we cannot see, and given that these dollars are different, we must hold ourselves accountable to a higher standard in alignment with the Bloomberg-Hopkins principles, which are the national standard for addressing the use of the opioid settlement funds, with a focus on supporting the spirit of the opioid settlement, including respecting that these dollars, again, are different. To be clear, the OAC is not endorsing the governor's proposed budget or the current budget plans presented by MDHHS. The OAC cannot support the proposed budget without detailed information on these appropriations. We urge this committee to request additional details on spending plans to ensure they align with statewide priorities and maximize the impact of these funds. Third, Michigan should explore a long-term endowment. The settlement dollars will run out. The needs will not. Gaps will remain. Therefore, we advocate for an effort to determine the potential benefits for the establishment of a sustainable endowment to be managed by the Michigan Department of Treasury. The Attorney General's office has verified that this allocation of funds is permissible, and the House Fiscal Agency recommends the introduction of legislation to safeguard the intended purpose of the fund. With an allocation of $282 million deposited into the Opioid Healing and Recovery Fund and over $200 million currently available within the fund, there is a timely opportunity to explore the possibility of a long-term endowment. This endowment would serve multiple functions. The OAC encourages the legislature to consider putting aside money that is currently in the Opioid Healing and Recovery Fund into an endowment while we are waiting for the needs assessment and other assessments that will strategically guide future investments. Doing so would protect against future funding gaps to support services beyond the life of the settlement. Additionally, an endowment would ensure that Michigan remains responsive and resilient in addressing addiction and behavioral health in the long term. To be clear, we are not proposing this instead of immediate investments. We are proposing it alongside them. We must invest today, but plan for tomorrow. Since our advent, the OAC has strived for meaningful collaboration with MDHHS. At times, we all know that this has been challenging. I want to express my gratitude to MDHHS for their recent positive engagement. During this time, the department has also indicated its intent to utilize or has utilized funds to invest in transportation and housing infrastructure, build technical assistance for local governments, and support systematic change rather than one-time programs. The OAC welcomes that direction and is committed to working in partnership. However, collaboration must also include clear communication, public reporting, and engagement in shared goals. Additionally, the OAC would greatly appreciate further clarity regarding the utilization of current and past funds. A detailed overview of the budget requests for this year and the 3-year plan would be invaluable, particularly how the recommendations were developed, the anticipated impact of the proposed appropriations, and their alignment with MDHHS's broader strategy. The OAC reiterates that it does not endorse the governor's proposed budget or the current budget plans presented by MDHHS unless and until we have the opportunity to review detailed information regarding these appropriations and engage in meaningful dialogue around the specifics of the appropriations appropriations within each pillar, the OAC has not been furnished with sufficient information to provide the informed opinion necessary to fulfill its statutory obligations to the public and the legislature. In conclusion, the state of Michigan has been entrusted with a once-in-a-generation opportunity to implement transformative investments aimed at addressing the opioid epidemic, as well as the broader addiction and mental health crisis. However, in the absence of a clear and data-driven strategy, there exists a significant risk of failing to achieve our full potential. The OAC's job is to ensure that doesn't happen. Let's work together to honor the lives lost, invest in the lives that remain at risk, and establish the systems that are deserving of Michigan's future. It is imperative that we recognize that these dollars are different and ensure they are utilized appropriately to support the health, safety, and well-being of Michiganders. By maintaining the focus at the forefront of our decision-making while also recognizing the unique nature of these funds through meticulous planning, community engagement, transparency, and accountability, we can collectively guarantee that these funds are allocated in a safe and equitable manner. Together, we are stronger. Let's keep the focus on the health, safety, and well-being of Michiganders. Thank you for your time, and I welcome your questions.
Told you she talks fast.
I was encouraged to talk fast.
I didn't think that was any encouragement. I think that's just natural. Any questions?
We've got 2 minutes.
Representative Roth?
And this was a question I had before. Thank you, Mr. Chair. We know naloxone works, but a lot of cases it takes a couple shots to make it work. Is there anything on the horizon, anything that you guys have seen that may be better or would improve that and less potential to use more naloxone?
Okay, so the real short answer is that naloxone is safe, effective, and the most common reason that people give multiple doses is not due to ineffectiveness of the naloxone when it's an opioid overdose, but because there either is a contaminant in it that is not an opioid that is contributing to the overdose. As Dr. Bagdasarian mentioned, the xylazine is very prominent in our drug supply here in Michigan, and it's actually not an opioid. It's not impacted by naloxone. When somebody is, what we know from EMS data, which is the trained individuals who don't have that emotional connection to the person who's overdosing, is that when they give the single dose of naloxone, that is effective in the event of an overdose. The most common reason that people give a second dose is because they haven't waited long enough for for the naloxone to actually take effect, which happens in minutes, but when somebody's not breathing, minutes feels a lot longer.
All right. Okay, thank you.
So a lot of you got in a lot. So, but you spoke a lot about the use of the settlement dollars, right? You certainly have your recommendations of the need assessment, the endowment, and then the intermediary ones as well, but also the transparency of those dollars and how they're spent. And it's my understanding that the department is sitting on several $1 million that was not spent last fiscal year, and kind of doubling that potentially for this fiscal year. And we just received a presentation on what the department is spending. Do you see that as and the settlement dollars are for the gaps and additional? Are you seeing that the dollars, when spent, and maybe can reveal to the committee how much has been spent, are just going into the same pots, or is there new dollars and new gaps being filled?
I think what's been challenging for the OAC to understand is what those gaps are without a evidence-based needs assessment. We're kind of throwing some things I don't know. I don't know how the department determined where they were using those funds. I think former Representative Stallworth said that he, in response to Representative Rogers' question, is going to be coming back to you all with some more information, but that's a key reason why we're recommending a needs assessment, is so that we can see what those gaps are, understand what those gaps are, and have it all in one place for folks. I think that some of that preliminary work is fortunately being done with the department, and I hope that they would be willing to work with the OAC on kind of putting all of that together, because as you saw, there were like 6 or 7 different bullet points of places to look, and that's hard to put together.
Representative Rogers.
Thank you. It seems that both of these committees, the task force and the OAC, are doing good work, but I'm curious on the interworkings of the communication, because it seems that there's a path going this way and a path going this way. So can you speak to what kinds of planning and I do appreciate you uplifting the needs assessment. We do other kinds of health needs assessments in most counties. And when I was a county commissioner, was frustrated at the duplicity. And so one of my missions as a county commissioner was to get our hospitals in Kalamazoo region all rowing in the same direction with the public health department. And it was past my time. I got 2 of the 3 rowing together, and then now all 3 of them collaborate on their needs assessment together. So that's kind of my thinking and my lens when asking the question about the communication between the 2. And then an independent needs assessment sounds like a great asset to help drive a strategic way of spending money. But
Yeah, we've, so between the task force and the Opioid Advisory Commission, Representative, oh, he left. No, he was behind me. Representative Stallworth is our kind of common person. And so as I mentioned, over the last few weeks, we've started to really try to work more closely together. And I'm hopeful that continues into the future. And I don't know if is that a fair? Yes. Okay. He says yes. That's fair. So I'm gonna remain hopeful that we can continue to work towards a more collaborative spirit to the work that's been happening across those 2 commissions. What the commission discussed at our last meeting in terms of the needs assessment is that you're exactly right, Representative. There are many other needs assessments that have been out there. What is hard and what hasn't, what is not available in most of those needs assessments, if not all of them, is the voice of persons with lived and living experience. And so that is something that is really important to access, which is why we've really focused on that community engagement part. And just to speak to why we would like to do individualized county reports and offer the same level of support to Michigan's 3 fires is because we know that, if you come to me and start talking to me like an MBA, I'm going to look at you like I don't know what you're talking about because I don't, right, as a physician. So how can we make sure that the county commissioners also receive that information for the counties, townships, and municipalities' share of the opioid settlement funds so that there's equitable information across all of the counties because, the resources that are available in Kent County where I live, a pretty resource-rich community in a larger county, are just going to be different than those that are available maybe in Sheboygan County. I have no logic to picking Sheboygan County. I just picked on Kent County because I live there.
Thank you. I appreciate the answer, and I just want to say, as a practicing health provider, I think we have seen the needle move. I have noticed that my own patients that have had elective surgeries or trauma or, all the things you get hospitalized for are receiving, in general, smaller prescription dosages of pain medications. So kudos, I want to give credit where credit is due to the medical providers that are prescribing less. I think it is making a difference. So I just wanted to say that. Thank you.
Piggybacking off of the needs assessment, Representative Rogers mentioned how hospitals and communities typically do a needs assessment. Is the things that you are looking for already within those documents and a criteria that they put forth? And then 2, just kind of provide for this committee of the length of time such a study would take, the cost as well as who would be responsible for doing the needs assessment?
Those are all very good questions. I think I have answers to some of them and not answers to all of them. What we have discussed is a needs assessment that would involve all of the community, so utilizing community engagement and community engaged voices. In order to do that, a significant portion of the funding would actually return to the communities to support that engagement and not be kind of sitting in the academic offices at a university or at MDHHS. So I think that contributes to a cost. We've also discussed that we don't, again, want to be duplicative to other needs assessments that have been done. So I think part of what we're referring to are the community health and needs assessments, and most of them have substance use, mental health, and housing and food security as within their top 10. And all of those except food security have come up today, right? So how do we utilize the information that's there? What's sometimes missing from those is kind of, and I think that Dr. Bagdasarian kind of started going here, so feel free to punch me in the ear if I'm speaking out of turn, but that the county-based mapping helps us identify those county hotspots. But what is difficult to do is to do kind of a local landscape analysis, so to identify where those treatment providers are. So as a physician treating patients in Grand Rapids, they're the three biggest treatment programs that prescribe medications to treat an opioid use disorder, which are the only evidence-based way to provide treatment that reduces the outcome of death, are all within like a 4-block radius. Like I can like throw a stone to the other two programs from my program, right? So, and I live about 10 miles out of the city. And if I go home, I have chickens in my backyard, and I had to call the county sheriff office in November because there was a horse walking on the street and I didn't know who the horse belonged to. So we get pretty rural pretty fast. I mean, I grew up in suburbia. I don't remember growing up and seeing a horse walking down the street. So we get pretty rural pretty fast. So are those resources available to all the citizens of Kent County, or do we need to be more strategic in terms of outreach, whether that's through mobile units, whether that's through brick and mortar, whether that's through telehealth, to ensure that we're reaching every citizen in Michigan, because it shouldn't matter where you live, whether or not you have access to safe, evidence-based addiction treatment, harm reduction, or recovery services.
So with the needs assessment, do you think that's mainly for the county dollars that are coming in, that local side dollars that are coming in, or is that for the state to make determinations?
I think it's both. I think we want to keep local dollars in local communities and make sure that the local governments have the information to be able to appropriate those funds. And Michigan Association of Counties does have a dedicated staffer to support the counties as well. But then we would be able to kind of heat map in collaboration with the Department of Health, where are those, what are those regional needs? So if, I guess one example that Dr. Bagdasarian gave was not every community has a harm reduction entity. Are there regions, versus counties that might need that support? And is that something that, that we address it with statewide dollars if we're looking at 7 or 8 counties in this, the same region that need a service versus a statewide, maybe there needs to be some engagement. I know years ago, back in 2018, the department hosted all of the deans for the medical schools. Do we need to make sure that that's happening so that every medical student has the baseline education and training in substance use disorders? And is that's a statewide need, right? So are there regional and statewide needs that would be identified to help us guide what are the best use of the state dollars to impact the broader population, so the local dollars can be spent on local solutions?
So you don't have an estimate on how long a needs I don't recall, maybe you do, of how long a hospital or community one. It's usually like 18 months, isn't it, that they end up doing so doing a statewide one
Would probably take us about a year.
a year. Okay.
Now, I think that there would be, there would be strategic ways that we could, again, work together to ensure that we get some preliminary data, some preliminary information that maybe doesn't have as much. The thing that takes a lot of time is in the community health needs assessment, as well as in this case, is that community voice. So can we kind of conglomerate some of the, math, data, and science is how I always say it, to give us some ideas, certainly, and we might be able to do that on a more timely. But to hear from the citizens, we would need time.
All right, I don't see any further questions, so thank you for taking the time, forming the committee. I'm sure this will continue to be a conversation, particularly as we go through the appropriations process, and it's my understanding the largest opioid maker hasn't done the settlement yet, so there may be additional dollars coming in later, pending what happens on the legal front. So thank you very much. Thank you to the department as well, taking the time and educating the committee on this important issue. To ask for a motion to excuse absent members. Representative Rogers, thank you very much. Prevails by unanimous consent. There being no further business, the meeting is adjourned.